All right, hello everyone. Let's go ahead and get started. Welcome to the Social Determinants of Health Thought Leadership series. This is the third of 5 discussions with experts from different disciplines and backgrounds between now and March 2022. Today, I'm really excited to have Dr. Katherine Theall, who is the director of the Mary Amelia Center for Women's Health and Equity and professor at Tulane University's School of Public Health. She will discuss the roles of community and structural violence in the production of health inequities. Dr. Theall's research focuses on reducing health inequities by understanding and altering neighborhood environments and social policies. We really welcome your questions and comments, so please use the chat to send them to everyone. We will have time at the end of the talk for Q&A. So without any further ado, I would love to invite Dr. Katherine Theall to give her presentation.
Great. Thanks, Lizanne. And hey, everyone, it's great to be with you today. I am here to talk about violence as a social determinant of health, which is what a lot of my work centers on. Hence some of the pictures. I focus a lot on the built environment. So I want to give you an example today. But I first want to also acknowledge where I'm coming from with this work as a white cisgendered woman with little lived experience in a lot of the work I study. And I grapple with that, but have and continue to center the voices and experiences of those who have those experiences in a lot of my community partnered work. So what I'd like to do today, and bear with me, this is my first WebEx controlled meeting, so I apologize if I mess up a bit. But yeah, what I'd like to do with the time I have with you today is to discuss 3 things. And I know you've had some great webinars so far. You've probably had a lot of conceptual models thrown your way, and I'm going to throw a few more at you as I talk about a systems approach to addressing health equity and social determinants, and then also in talking about violence as a key social determinant. And then what I really want to do is give you an example of my community partnered work aimed at addressing one social determinant and a lot of those practice-based challenges we have encountered and continue to encounter, some food for thought as we really address the social determinants. So that's what I'd like to do. First, I do want to thank, though, all of my community partners, all of my colleagues. None of this research I will present, of course, was conducted alone. It's always in a team. And we've been lucky enough to have a very interdisciplinary team probing us to ask great questions and do great work. I really want to acknowledge the partners on the ground for the work I'll be talking about, specifically the City of New Orleans Office of Mayor LaToya Cantrell and the Gun Violence Office of Gun Violence Policy, Was Cure Violence. They've changed their name. Also, the Center for Employment Opportunities. This organization is a wonderful reentry program, and they're doing a lot of our on-the-ground work for the intervention I'll be talking about. Also, the Office of Institute, of Women in Ethnic Studies, a long-term partner in this work, and doing some really exciting, at least planning on how we get the word out there, assuming some of the research will be successful as an intervention. And then I want to acknowledge NIH, my funders, and the Robert Wood Johnson Foundation. Part of this work is funded under the Evidence for Action program, which is one arm of their Culture of Health framework. I'd urge anyone to take a look at that if you're wanting more. It's a great framework in thinking about health equity and social determinants. Okay, so first some framing. As we think about social determinants and health equity, there's been a push to move beyond, of course, our public health and medical institutions and systems into other sectors. And there's also been a push to think about this movement in a systems-based approach. I have an analogy here. This is from Gilbert Key and Maggie Henkin's work. This was a publication that came out in 2021, and a great analogy talking about structural racism and really differentiating structural from institutional with the buckyball. So this is a molecule of carbon atoms arranged in the form of a soccer ball, where each atom represents an institution. So healthcare, employment, housing, criminal justice, education. And within each of these institutions, there are norms, racialized norms, practices, policies that can be harmful, institutional racism, but of course, other forms of oppression as well. But the structural component and structural racism derives its strength and resilience from these interconnections between the institutions. And so I want us to, kind of keeping in mind as we work within these sectors to address social determinants, always having that lens of the interconnectedness, because to really dismantle the impact of these systems, particularly structural racism on health and health equity, we're going to have to attack systems. And so there's a lot of work moving this way. We have a long way to go, in public health and doing that. So each of those institutions, are social determinants, some of them in their own right, and they definitely create social conditions that shape health across a life course. One key social determinant that multiple institutions shape, and I'll show you a conceptual model of that in a bit, is violence. And we all know violence is important, and it's epidemic and almost pandemic in its own right, especially during the pandemic. There's been an increase in violence across the globe. And I think of it as really one of the most important social determinants of health, given its implications for health, social, economic outcomes, you name it. It really cuts across so many different domains and is a leading cause of death and disability, as you know, affecting individuals, their families, their communities, their societies. And we have great interventions and practices and even policies that do seem to be working to address violence. But we in public health, taking that population and public health approach, know that we need more that address the base of the pyramid. If we think of the public impact pyramid, which I have here on the right, that these are going to have bigger bang for their buck. We may move the entire population curve and address violence if we can focus on those more distal factors. But we actually don't have a lot of interventions, place-based or other, that really tackle those levels. So I'm going to show you one that we're testing out in my work, but again, there's a need for more. And we use this public health pyramid in a lot of our conversations with our partners, particularly outside of the public health sphere, to get buy-in on our approach and the angle we're taking. Noting that we need, greater focus on the base of the pyramid for more population impact, but acknowledging the importance of the individual level interventions and, of course, targeting those most at risk. Definitely need top down and bottom up, but it has helped in framing our position on this. As public health practitioners, I think we can all acknowledge too that we need more levels to this pyramid, which may already be out there, and I'm behind on my pyramid additions. Okay, and when we think about not only violence, but other social determinants of health, it's really key that we have a life course lens and frame it in a way that thinks about how these conditions shape health over a lifetime, even across generations. And there's a number of studies that have linked social determinants to health across all of adulthood. Our work in particular has focused on violence. Shown here are just a few of our studies that have linked living in a violent community to biologic and behavioral stress in children. And so what do I mean by that? We have looked at one biologic marker called telomere length, which is the cap of our chromosomes. It shortens normally with every cell division, but it shortens quicker with certain exposures. And the quicker the telomere shortens, the more quickly the cell dies off. And of course, cellular function is impacted. So many people think of telomeres as a biologic marker of aging. And we've linked this in children to locally in New Orleans, but also nationally too, to find that children living, and these are young children in middle childhood age groups, but those kids living in neighborhoods experiencing high rates of violence have shorter telomeres on average than those who don't. And that has great implications of the biological trajectory for health over a lifetime. We've also looked at behaviors in childhood and how they may be linked to conditions such as violence in the community, and have found greater rates of externalizing behavior, other behaviors that again might have implications for long-term health and social outcomes. So putting that plug in there, I think it's an important one as we think of social determinants as public health practitioners. All right, and like social determinants of health, where there are many conceptual models, there are equally just as many for violence and community violence in particular. This one I have here is part of the Biden administration's series on community violence interventions, which is a webinar series, a wonderful one for anyone interested. And I like the way it's depicted violence in multiple forms, so individual and collective trauma and victimization, as well as interpersonal violence, but how they may be directly impacted by structural factors or structural determinants, things such as unhealthy built and social environments. It's kind of hard to read my slide here probably, so I'm gonna look up too, but you probably can't see this on your slide either. Extractive development, poor quality institutions, low density of structural supports and systems. We can go on and on with some of those structural determinants that do directly shape violence and forms of violence, but also the historic context, racialized norms, practices, and policies that also shape these determinants. So these collectively have a direct role on violence, and they have an indirect role through mediators, which are also social determinants in many cases. Things like limited access to financial and social capital, increased social and economic hassles, decreased supervision or supports. These are important mediators to consider too. So that's, kind of a framing that has been important. And I would add to that these structural determinants, including racialized norms and some of these historical and more entrenched practices too, can be thought of as structural violence. And we often refer to that, in our world and in my work and kind of in our field as a form of structural violence, which really refers to the multiple ways in which social, economic, and political systems expose different populations to risk and vulnerabilities, and of course, leading to health inequities. And these can take on many forms, right? Racism, sexism, ageism, ableism, lack of opportunity, you name it. There's multiple forms of this. And as we all know, structural violence is not new. One of the probably most common examples and studied examples as well is redlining. And so the process by which, mortgages and home ownership was denied to people of color across the US mainly. And this has great implications for how the neighborhoods we see today were shaped historically, but including what's happening in these neighborhoods in present day. So what I have here on your left is a map of New Orleans back in 1939. This is a map of our redlining pattern. The Mississippi River's down on the south and Lake Pontchartrain's down up on the north. And you'll see a few maps of New Orleans as I talk about our work here. But you can see these redlined neighborhoods back in 1939, and they map quite well onto current health and social outcomes, including, shown here, rates of violent crime, as well as blighted property violations. So this is kind of a double map with properties that maybe are in disarray, vacant, abandoned, blighted property in some way, and then violent crime rates where the darker the purple hue, the greater the violent crime. And you can see, again, comparing the two maps, they map quite well. And this is violent crime from 2018 and 19. We see the same pattern, again, if we look at domestic violence. This is, again, blighted property violations and domestic violence call violations. These are not substantiated cases, but they do give us some indication of where domestic events might be happening. And again, the orange hue represents higher rates, and we can again see higher rates in these redlined areas. And finally, if we think of yet one more form of violence, looking at police encounters and the rate of stop and frisk or pat downs among Black individuals and Black residents across New Orleans, we also see a similar pattern. And this is not new to New Orleans. Many of you have probably seen kind of maps comparing redlining to current health and social outcomes in many cities across the U.S. But I think it is important as we kind of keep social determinants in mind and think about how they were developed. But place can be changed. So a lot of my work is focused on neighborhoods and health, and really thinking about how they shape health inequities in particular, and how we can change them. We've done a lot capitalizing on some natural experiments, but what I want to talk to you today about is an intervention where we're trying to change neighborhood conditions. And this is built off of a semi-long time partnership, not super long, but in the last 5 to 8 years, with our city's code enforcement office, trying to see if I can evaluate some of their work around blighted property abatement as a low-hanging fruit, from an interventionist perspective, as a public health interventionist. And then that led to greater conversations, greater collaborations, which finally we were lucky enough to find some money and support to test a randomized control trial aimed at remediating vacant properties and land, in the hopes of looking at violence as an outcome, but also other health outcomes as well. So what you see here is top and bottom. The top pictures, and left and right, are before and after. So I have a picture of a vacant lot, and our treatment for this vacant lot is to mow the grass, remove the debris, plant a tree or two depending on the lot, and also install a small fence. And so that's what treatment looks like for the vacant lot. And for vacant homes, of which I should say for both lots and homes in New Orleans, we had a problem even pre-Hurricane Katrina with blighted properties. So it's a big issue, and one that has been linked to, of course, health and violence related outcomes. But for the homes, the intervention is basically making the home look lived in. And so you can see the before and after here. This is a vacant home, but just making it look lived in enough so that perhaps the implications for reducing that blight and that eyesore are seen by the residents. And that might entail coat of paint, replacing windows, doors. This picture here was a doozy, but we've had some that are worse than others, and it just depends on the level of the home. And so we're looking at this across the city, and we're building on a colleague of mine's work and others. There were a series of trials conducted in Philly, also looking at the impact of vacant property remediation on violence. And in their study, they found an almost 30% reduction in firearm violence just by cleaning and greening vacant lots. They found a reduction in nuisance crimes, reductions in self-reported depression, more reports of going outside, more enjoying outside and relaxing, you name it. Definitely a win-win science in terms of both violence prevention and public health outcomes. They also found a return on investment of about $25 to $300 for every dollar invested, and it's a pretty low cost intervention with potentially far-reaching implications for health. So that's what we're trying here in New Orleans, and it is a cluster randomized trial, with clusters being these small geographic areas that I'll show you in a bit. And we have 194 of these that are randomized. And we have a block randomization pattern, and we really have two arms of this intervention, which the figure here probably doesn't totally depict, but we have a set of clusters that have vacant buildings, which might be mostly homes, but some other commercial property as well, and vacant lots. And so we're treating, everything within that cluster. We have another set of clusters with just vacant lots being treated. And then we have control clusters. And we're following them for a year, pre, post, and looking at a host of outcomes through a variety of methods, including ecologic level analyses, difference in difference, but also multi-level. We have a cohort of residents nested within these areas. And as I mentioned, we're looking at a host of violence-related outcomes, including domestic and family violence, which hasn't been done before, in this scheme, or at least in the Philly trials. But we're also looking at some social and public health outcomes, such as collective efficacy, civic engagement, of course, mental health and substance use, and well-being and safety. And the other difference between the trials here and a lot of the Philly trials, which to date have been the only randomized designed to look at this treatment, we're looking at moderators in the neighborhood. So what other conditions might impact or change the course of our intervention? Things like alcohol density, maybe neighborhood walkability. You can think of a lot of other social conditions in the neighborhood that might negate the impact of just cleaning up vacant property. So that's what we're up to in a nutshell. This map is a map of all of the clusters to give you a sense of these geographic areas. They're small, about 1/8 of a mile, and we have 194 of them across New Orleans, or Orleans Parish, county equivalent for those of you not in Louisiana. And so we've randomized these in a block randomization pattern with, for those familiar with New Orleans, the West Bank being one block to ensure that we have both treatment and control clusters in the same block. New Orleans East being another block, and then the rest of New Orleans being the third. And so this spans 23 neighborhoods. And, as a community partnered CBPR researcher, the thought of authentically partnering across 23 neighborhoods in the city has been a big challenge, which I'll mention, but I'll talk about some ways around this. But it's a huge project, and I think it's, from a public health angle, needing more evidence for impactful interventions with a strong design are needed, but the challenges of that are real, and there's something we've had to grapple with. So I wanted to talk about a few. And first, I think the cross-sector and interdisciplinary work that I've done, for many years is challenging. And, from a cross-sector approach, really getting out of public health into housing, into code enforcement, I'm definitely in a world that is new to me, has taken a lot of buy-in. And so that has taken conversations, with code enforcement, for example, to help them understand the value of looking at the health implications or violence-related implications of their work, talking to the health department about, again, looking at the impact that code enforcement's work might be having on health or violence. Our health department, rightly so, has had a lot of competing priorities in the last 2 years, but nonetheless, our commissioner has been wonderful. She and I actually co-chaired she was our chair for a NACHO conversation and symposium this summer, but it's been tough. It's taken a lot of time and conversation. And we've also built, before we started the trial, a data integration system for the city with Tulane. There's many platforms out there, but I found that at least helped to spark some of the conversation as different offices and divisions could see different data sources, how they might come together, not only for our little research project, but really for monitoring some of their day-to-day. And so the buy-in has been tough, definitely at kind of the city, the practice level, but also with our violence prevention partners. As I mentioned in the health impact pyramid piece, we work closely with what was Cure Violence and Ceasefire, gone through a few names here in New Orleans, but really getting those on the ground focused on violence prevention to understand our public health angle and, why we think just changing blighted property in a neighborhood is going to impact crime has been challenging, but we've come a long way. And again, it just takes multiple conversations, multiple examples Again, not in research or academics terminology and language, but in something that meets partners where they are for sure. The other challenge within this, and this is not new to any of you working across disciplines academically, is the disciplinary differences and priorities. And while it is challenging and takes time, I think, to cross that discipline and discuss what a confounder is to us in public health versus what that means maybe to sociologists, it offers great, I think, questions and approaches to the research. On our team, we have, architects, we have lawyers, we have sociology, we have medicine and public health, but I think the project has definitely only grown and become much more rich with these interdisciplinary collaborations that do take time. So always realizing that has been definitely a learning process. Another challenge has been, as always, the multiple layers of community engagement and partners. Anyone working in the community partner participatory space knows that these take time, and it's hard to, once a grant announcement is out, jump on this authentically with a partner unless you've been partnering with organizations or individuals for years and really co-design the research, co-design the process. Rarely do our funding announcements, allow even for that pre-window to happen. We have been lucky enough with some of our partners to have that space and to have that long-term partnership that allows for this to happen. But it also means that we're partnering with specific community partners. And what I've learned in this work, of course, we all know there's local CBO and NGO politics, but is how challenging that can be, right? So we've been partnered with maybe partners in certain neighborhoods that maybe weren't the best partners to others in those neighborhoods. And so kind of navigating those while staying a neutral academic body has definitely been a challenge. And of course, always having that collaborative learning from both ends, not only the research, but we've learned so much in this process, as I always do, all of the community partner-based research. It's definitely collaborative learning, which is wonderful and a challenge. But keeping that all in mind and the equitable partnership, I think, from a funding perspective with federal grants, at least where I sit as in an academic institution, it takes a lot of conversation and understanding with partners as to where all the money goes, right? That $5 million grant, which we as researchers see half of at the institution, I think having a lot of these conversations is important. And it's a challenge we face too. The other, I guess, within that framework is equitable allotment of the money. And to give you one example, we were just funded, are really excited and thankful to be funded as a CDC Youth Violence Prevention Research Center. We have more than 7 partners involved, and we all were at the table at the beginning writing the grant, constructing the budgets. Every partner is doing a different piece of the work, but having partners at the table inquiring about how much money other partners are getting and wanting to see these budgets, and then it's realizing everyone is doing a different piece of the pie. And so that's a challenge and has been. The other challenge I've grappled with, and we've talked a bit about this in our RWJF space, is we know we need more evidence to support these public health practice policy-based approaches. But I guess what constitutes evidence? We are excited and dead set about this randomized trial and its design and the scope of it across 23 neighborhoods in a city like New Orleans. But I guess to what end and at what cost does that come to certain residents, even waiting that 1 year until we treat controlled properties? These are things we've had to really grapple with, and keeping the scientific integrity and the design intact. Telling communities enough, but not too much to bias the intervention has really been a big challenge. So I wanted to mention that. And then finally, the challenge of sustainability, the funding and the resources to do the what's next, the policy, the advocacy. This is an extremely, I think morally I'd focus on this, even though we're not funded to keep these parcels or these homes maintained. We know good and well that the city may not have the funding to keep this going. And so we're trying to work now to see what we can do to put in place systems and more sustainable long-term effort for this, but it's not something written into the grants after the 5 years are up. The money's done. So how do we really structure ourselves now to make it more long-term, not only for blighted properties, but I think in the space of other social determinants too. And so to that end, we have formed a CAB, but not a community advisory board, a community action board. We, at least in New Orleans, have many health-related CABs. A lot of the same players are always at the table, and coming in a very advisory role. So I've always struggled with that and wanted to do something different with this project. So we organized a group of organizations focused on place-based changes, and that might include like the Water Collaborative, looking at flooding and sustainability from the climate angle, or SOUL, which is a great reforestation group here in New Orleans, which is actually deforested. I didn't realize till I got to know SOUL. Play Build New Orleans, a very diverse group of actors, but all aimed at changing place and space for health and other outcomes. And so it's been a wonderful kind of side project to the research as we think about sustainability, about grants, about what we need to put in place all of the changes that we're working on. And, in our case, can some of these groups repurpose, the lots, the homes and whatnot. So that's been a big piece. In some, I think, I've shown you one example of built environment as not only a social determinant, but one that might impact another social determinant, violence. And I do think there's great potential. I think there are a lot of changes we can do in the built environment if we're working locally to make change. I say low-hanging fruit. There are a lot of challenges to that as we work outside of our sectors, and we're just working outside of one small sector. But I think keeping in mind that addressing the built environment only addresses that, that one aspect, and not the systems that created some of these neighborhood conditions in the first place. And so it's a lens we definitely constantly keep in mind in our work. And we are at the table. So in the Healthy Neighborhoods Project, we are, working with both the health department, code enforcement, the mayor's office, the Office of Neighborhood Sustainability and Investment. We're there at the table. And so really starting to think about how we can use that space to think more about systems. Again, not something we're funded to do, but I think how do we really always have that lens in our work is really important. And I think, we have done, I have a snip here of a publication we did as part of a larger Kellogg project with the National Collaborative for Health Equity, Brian Smedley's group at the time, thinking about health equity and thinking about the role of public health. And we only dug into the Louisiana context for this, but found that most public health organizations, governmental and non, did feel that we could play a role as catalysts. And I truly believe that too. Most people care about health, right? It's maybe a little easier to get health in all policies, or to use health as a driving force, especially now, even more so with the pandemic than in other times. But I do think we can be catalysts, and I think that's also important to keep in mind. And it's overwhelming to think about social determinants, about these systems, about how we actually address them. But I think we do play an important role. And so can take those baby steps as we go along the way. And that's it. Thank you guys for having me today. And I look forward to some questions and discussion.